So in the second video on Pediatric DKA, let's talk about treatment. And remember, our DKA was defined by having a high glucose, having high ketones, and an acidosis as well. And everything is complicated by a hypokalemia that might look like a hyperkalemia. The pseudo-hyponatremia will be there. Dehydration, which can be pretty profound. And of course, the thing in pediatrics that makes it different is the worry of cerebral edema that can happen. Not really sure what causes it, but it's thought to be due possibly to the fluid and the zealousness by which you try to correct things. And this is a problem because it could cause herniation and death, or even just bad neurologic outcomes. And there are a couple of risk factors actually for getting pediatric DKA-induced cerebral edema. New onset diabetes, a younger age, longer duration of symptoms, if the acidosis is really bad, if they're hypocapnic, if the fluid is given at a faster rate, we think possibly, age less than 5, azotemia, treatment with bicarb. So all of those things possibly could increase the risk of cerebral edema. Now, there was a study you can see here that I did this on June 19th, and a couple days ago there was a study that came up from the PCARN group that's questioning some of the fluid-related things. So more will be coming out on that later. So let's tackle first dehydration. So in adult patients, we're pretty liberal about fluids. We'll give patients many, many liters. Now in pediatrics, we're a little bit more cautious because of the worry of the cerebral edema. So we'll start with a bolus, 10 to 20 cc's per kg over 1 to 2 hours. And you can repeat that if the patient is in shock. But you don't want to exceed 40 to 50 milliliters per kg over 4 hours. We don't want to give too much fluids. So after this first bolus, then you're going to give fluids at maintenance rate, maybe a little bit more than maintenance. And if you can't remember, so if you don't remember how to calculate maintenance fluids, I'll go over it quickly here. For the first 10 kgs, you give 100 mils per kg over 24 hours. For the next 10 to 20, it's 50 per kg over the next 24 hours. And for every kg over 20, it's 20 mLs per kg over 24 hours. Or you could use 4-2-1 if you're looking for doing it over an hour. Now, you never want to exceed 2 times maintenance because there's the thought that that might increase the risk of cerebral edema. Now, the other thought is that if you give a lot of sodium chloride, that's a huge chloride load, which then creates a non-anion gap hyperchloremic acidosis. And so some people recommend maybe you can give lactated ringers or Plasma-Lyte. But I believe there's no study that shows there's any difference in giving either of those. So how dehydrated is this child? Now, there are ways of estimating dehydration in pediatrics that you could look up somewhere else, but it's difficult in the diabetic ketoacidosis child because the increased Kussmaul respirations from the acidosis and all the proteolysis and lipolysis can really make them look more dehydrated than they are. Now, conversely, the increased osmolarity of the blood pulls fluid out of the cells and into the intravascular volume, which can actually make them look less dehydrated. So it's very difficult to estimate how dehydrated they are. And so some people say just assume there's a 6%, they're about 6% dehydrated. If they're moderately dehydrated, moderate DKA, you could say 5 to 7%, and severe 7 to 10%. But this is just a guess. It's just very challenging to know unless you actually have weights before and after the DKA. It's almost too difficult to know. Now, let's talk about something called the 2-bag setup. And what you have here are 2 IV bags connected together and into one line, which is then going into our patient over here. And these bags are identical with the electrolytes that they have in them. So if you're going to use normal saline, then you're going to have normal saline in both. If you're going to have 20 milliequivalents of potassium phosphate in both, or potassium acetate in both, it's going to be in both. Now, the only thing different between these 2 bags is one is going to have 0 dextrose in it and one is going to have D10. So what this allows you to do is to control the amount of sugar that's going in, because the fluid is going to be the same, and then it's ultimately going to mix before it goes into the patient. And so different hospitals are going to have different protocols, so look at your protocol. But it'll be something like this. Above a certain value, let's say 250, you're going to shut off the D10 because there's already enough blood sugar there that we don't want to add more. So all of the fluid is going to come from this bag here. Now, below a certain value, like 150, we're going to be fearing hypoglycemia as we continue to give insulin. And so you're going to shut off the D0 bag and give all D10. And in the middle, you're going to give maybe a mixture of half and half. Now, at our hospital, we use a slightly different, slightly more detailed mixture of this, but there's a table that you can follow. And so look up your table. If you don't have one, this is an estimate of kind of what would be happening here, with the idea being that you keep doing AccuChecks, and as you need to, you can turn off one bag and turn on the other one, and you have better control of the patient's sugar. And so this gives you faster control, and it's probably also cheaper because you're not overloading them with one bag of fluid or throwing away another bag of fluid. So now let's talk about insulin. And we're going to use regular insulin. We're going to give it through a pump. And the thing that we want to avoid is dropping the glucose too quickly, because we think that might also cause cerebral edema. So you're going to give 0.1 units per kg per hour with no bolus. And you're going to keep this going until the anion gap closes or the beta-hydroxybutyrate level is normal. Now, look, we're not basing this on the level of sugar. That's the whole reason that we have that 2-bag method, because we know that we're going to drop the sugar and we're going to have to supplement the sugar. And once the gap is closed, then you can transfer off of the IV to the sub-Q insulin. But until then, we're going to be using IV insulin. But wait, we cannot actually start the insulin until we know what the potassium level is, because giving insulin to someone who's hypokalemic, it's going to drop it really quickly. So again, figure out what the levels are at your hospital, but it might be a potassium of 5.5 and 3.5. So anything above 5.5, you know that there's enough potassium outside the cell that you have some space so you can start insulin. Now you're going to have to keep checking these potassiums every hour because it's going to drop. And once you get below 5.5, now you're going to supplement the potassium so that we don't drop it too far. If it is below 3.5, then you want to give no insulin, just fluids. So we cannot start this insulin until we know what the potassium is. So now let's talk about the dreaded cerebral edema. And it could start 4 to 12 hours after treatment, or even as late as 24 to 48 hours after we start treatment. And it's thought to be due to a rapid correction of the glucose or rapid delivery of fluid, but it's also happened to people who have not had any treatment whatsoever. So it may not have anything to do with fluid delivery, but we don't know that yet, and so we're going to continue under that assumption. Now, the problem with this is you can also get brain injury by not giving enough fluids. So the hyperperfusion is going to lead to cytotoxic and ischemic injury in the brain. So it almost seems like you're damned if you do and you're damned if you don't. You can't give too much fluid too quickly, but you can't give too little fluid without causing problems. So we're going to give fluids based on the thing that we calculated before and do frequent neurochecks every hour. And we're looking for any drop in the GCS, headaches, altered mental status, focal neurologic deficits, or even incontinence. And if you do have any of those symptoms, then you need to start initiating treatment. And treatment is going to be increasing the head of the bed, so putting the head of the bed up, decreasing IV fluids by the rate by a third, starting mannitol, a half to a gram per kg over 20 minutes. And if you have no improvement of the neurologic function, you can repeat that after about 30 minutes to 120 minutes. And the fourth thing you can do is do hypertonic saline, 3% normal saline at about 5 to 10 mLs per kg over 30 minutes. And that's going to hopefully decrease your ICP, increase your cerebral perfusion pressure, as well as your MAP. You may need to intubate these patients as well. And if you do intubate them, you may consider hyperventilating, but make sure you keep the PCO2 above 22. Otherwise, it's been shown to have worse neurologic outcomes. So let's take a look at this treatment plan again. Right, so we have our patient with DKA. The first thing we're going to do is give them some fluids, and we're going to start with a bolus, 10 to 20 mLs per kg, and then we're going to give the rest based on maintenance, and we may increase it assuming that they're about 6% dehydrated. And that's going to be given using this 2-bag setup. One of them has no sugar, one of them has sugar, and then you can turn on and off the bags or mix them together in order to keep the patient from becoming hypoglycemic. The next thing that we may want to consider is insulin, but before insulin we got to check the potassium, because if the potassium is low, we can't start the insulin until we've improved the potassium some. And if that is the case, if we are able to give them insulin, we're going to give it in a regular insulin in a pump, 0.1 units per kg per hour, until the gap closes. Now the thing that we want to worry about is cerebral edema, and so we're going to want to check for that. And we're going to do Q1 hour neuro checks, and if we do find that there is a problem with that, there's a bunch of things we can do in order to try to ameliorate any possibility of cerebral edema. And as I mentioned before, I'm recording this on June 19th, and on June 14th of this year, there was an article that just came out in the New England Journal of Medicine called A Clinical Trial of Fluid Infusion Rates for Pediatric Diabetic Ketoacidosis. And it was a 13-center randomized controlled trial that looked at giving fluids fast versus slow and using normal saline versus half normal saline. And what they were looking for was there any change in the Glasgow Coma Scale in these patients. And they had about 1,400 patients. 48 of them had some sort of brain injury, and they found that there was no difference among any of the groups, whether it was fast or slow, or whether it was 9.9 or half normal saline. So more to come on this. We're going to have to figure out whether the rate of administration of fluid or the amount of sodium chloride in the fluid actually has any difference on whether it causes cerebral edema. But for now, follow your hospital protocols and be careful with the fluids. And that's it. Okay, thanks a lot.